molecule, but it was a largely misleading message, and more importantly, the message becomes transmitted in a manner that's completely inconsistent with what the data showed. Now, the authors did conclude that caution should be exercised before extrapolating the LRC-PPT findings to cholesterol-lowering drugs other than bile acid sequestrants. And furthermore, they noted that the LRC-PPT was not designed to directly address whether cholesterol lowering by the diet prevents coronary heart disease. And that's true, it did not. However, Basil Rifkin, the late Basil Rifkin, the NIH director of the LRCCP, said in Time that year, it is now indisputable that lowering cholesterol with diet and drugs can actually cut the risk of developing heart disease and having a heart attack. And most of us in this room are probably old enough to remember that. I remember this cover quite well in 1984, which was in many ways the final nail in the casket of fat and cholesterol. Rifkin went on to say that the LRC results strongly indicate that the more you lower cholesterol and fat in your diet, the more you reduce your risk of heart disease. So why'd they exaggerate? Well, as he acknowledged, it's an imperfect world, and the data that would be definitive is ungettable. So you do your best with what's available. This is really a variation on the precautionary principle. A couple of weeks ago, I write a blog about this kind of stuff, and someone asked a question about what book would I recommend to help really understand the scientific method, and I had to think about it for a couple of days. But I think the original work of Francis Bacon, which many people argue or would suggest at least was the cornerstone for the true development of the scientific method, would probably be a good place to start. In sciences that are based on supposition and opinion, the object is to command assent, not master the thing itself. So in 1984, the NIH Consensus Conference issued the following conclusion. There is no doubt that a low-fat diet will afford significant protection against coronary heart disease to every American over the age of 2. The Surgeon General at the time, C. Everett Koop, went on to say to this that the data proving the link between the consumption of saturated fat, cholesterol, and heart disease was stronger and more convincing than the evidence linking cigarette smoking to lung cancer. Now, I always appreciate what Dan Steinberg, who was actually the chair of the panel and the co-principal investigator on the LRC-PPT, had to say about this. If there had been a true consensus, you wouldn't have had to have had a consensus conference. In 1989, the National Academy of Sciences, Diet and Health released a 1,300-page document, The Implications for Reducing Chronic Heart Disease. Highest priority is given to reducing fat intake because the scientific evidence concerning dietary fats and other lipids and human health is strongest, and the likely impact on public health is the greatest. It's as though there's data we're not seeing. Okay, let's talk about the evidence post-consensus. In 1990, which was really the apex of the low-fat movement in this country, a very famous physician named Dean Ornish and his colleagues published a study in Lancet, which was called the Lifestyle Heart Trial. This was published in 1990. This was a study that took about 56 men who had known coronary artery disease. There were a number of entry criteria. You couldn't have had a heart attack within the 6 weeks leading up to the test, but you were clearly a high-risk patient. And they were put into 2 groups. The first group was the treatment group, and the treatment included smoking cessation, a low-fat vegetarian diet that was not permitted to include more than 10% total calories from all fat, no flour, no sugar, stress management, and vigorous exercise. The control group was allowed to continue smoking, eating as they saw fit, not exercising, no yoga, eat all the sugar and flour you want. At 1 year, the patients were followed up. Now remember, this is a small trial, so there was no difference in the number of deaths. One person did actually die in the low-fat arm. He had a heart attack while exercising, but the study was not at all powered to detect that difference. The end point of this study was something quite novel, which is sort of what made this a very special study, which was they subjected all of these volunteers to coronary angiography. So at the beginning and the conclusion of the study, every patient underwent a very invasive procedure where a catheter is stuck into their femoral artery, dye is squirted into the arteries of the heart, and you take pictures, and from that you can tell how occluded the arteries in the heart were. Turned out the treatment group showed a significant reduction, about a 20% reduction in the lesions within their heart, while the control group had actually progressed about 5%. So this study was really viewed as a landmark because it showed that through lifestyle, without medication, you could reduce coronary artery disease. You could reverse atherosclerosis. The problem comes when you try to figure out what actually did it. Because there were really a heck of a lot of interventions here. You know, I tell the story sometimes, and I'm being a little facetious, but my background being in oncology, I think a lot about how cancer trials work and how good science, you tend to isolate variables. So it's sort of like me saying we're going to do a study where we're going to take two groups of patients with stage 3 colorectal cancer. In both patients, we're going to remove the lesion, and then in one group we do nothing for a year, and then in the other group we're going to do radiation, we're going to do 3 drugs, we're going to do daily massages, the visits from kittens, we're going to throw everything at them. And then in 5 years, we will find possibly that group in that arm did better. And that would be great if we kept our conclusion to what the data showed us, which is next time you're confronted with a patient with stage 3A colorectal cancer and you've done the operation, if you want to increase their chances of survival, you need to do these drugs, these kittens, these massages, these this, that. But imagine I came away from that saying, you see, drug number 2 is what's saving lives in colorectal cancer. That's exactly what was done here, and with all of these studies. Now, I don't know if any of you are familiar with the Cochrane Collaboration. This is a group of 28,000 volunteers around the world. It's a nonprofit organization made up of scientists, physicians, folks who are interested in public health. And they have a wonderful mission, which is to take the complexity and ambiguity in science and try to distill it down to what is known. And so if the Cochrane Collaboration gets involved in something, it's a really big deal. It's considered a significant problem. And so in 2001, the Cochrane Collaboration published a meta-analysis titled Reduced or Modified Dietary Fat for Preventing Cardiovascular Disease. They looked at 27 well-controlled randomized trials of 10,000 subjects followed for an average of 3 years each. And they concluded from this that no effect on longevity was observed and there was no significant effect on cardiovascular events. Now, I'm personally very skeptical of meta-analyses. One of my mentors once gave me a great analogy, because a meta-analysis takes a whole bunch of studies and tries to accumulate it. And I remember once I was quoting some meta-analysis to him, and he said, you know, Peter, 1,000 sow's ears makes not a pearl necklace. So when you start with a whole bunch of junk, it's quite possible you don't get much out of it. So you always have to take a meta-analysis with a grain of salt. Nevertheless, 5 years later, they followed it up with a subsequent meta-analysis titled Multiple Risk Factor Intervention for Primary Prevention of Coronary Heart Disease. Now, they looked at 2 interventions, the lowering of blood pressure and cholesterol. These are 2 separate things, in 10 well-controlled trials that encompass 900,000 patient years of observations. And they commented or concluded that the pooled effects suggest multiple risk factor intervention had no effect on mortality. This is probably a study that most people in this room have heard of at some point. The Women's Health Initiative was really an enormous study. It went on for a number of years, and it examined a number of questions, including the role of estrogen, the role of calcium, the role of diet in the health of women. And many people have criticized it because it only looked at one demographic, which was, people ask me, like, how do you think of like the difference between men and women? And I sort of think of 4 different types of things on earth that are humans. There are children, there are men, there are premenopausal women, and there are postmenopausal women. And I say that only based on my experience with how, and I'm not being a woman or a postmenopausal woman, I don't want to speak out of turn, but I have really noticed, and I think physicians in the room will also comment, that when a woman goes through menopause, a lot of hormones change in her body, and her risks really change from what might have been happening before. So the point I want to make here is people have criticized the Women's Health Initiative because it only looked at postmenopausal women aged 50 to 79. But nevertheless, within this population, they looked at nearly 50,000 postmenopausal women, and this was not a cohort, this was a prospective design, this was an experiment. and they divided them, so you got 25,000 women in each arm, and they were randomized to either a normal diet or a low-fat diet. And for 6 years, total fat consumption in the low-fat group had been reduced by 8%, and saturated fat had been reduced by 3%. They also, of course, had a commensurate rise in their increase in fruits, vegetables, and whole grains. The conclusions of this study, which were published in 2006 in JAMA, were that the intervention did not reduce the risk of coronary heart disease or stroke. A low-fat dietary pattern did not result in a statistically significant reduction in the risk of invasive breast cancer. There is no evidence that a low-fat dietary pattern intervention reduced colorectal cancer risk. And the low-fat dietary pattern among generally healthy postmenopausal women showed no evidence of reducing the risk of diabetes. So we've got a little bit more to go. We're almost done. It's warm in here. I feel it as much as you and more. But I want to talk about a couple of other diet trials that have been often talked about in the media. So one of them was published by Foster and colleagues in the New England Journal of Medicine in 2003. Now, you got to remember what was going on in 2003. So most people think that Atkins kind of came along at that time, but actually Robert Atkins had been around since the 60s. And in fact, if you ever want to be shocked, I recommend looking up the Senate hearing of Robert Atkins in front of the McGovern Commission in 1972, because by that point, Robert Atkins had an enormous practice in Manhattan where he was treating patients with diabetes and obesity with a low-fat diet, a low-carb, high-fat diet, and he was being viewed as an assassin, effectively, a clinical assassin. And he spent a lot of time in front of that group. But nevertheless, in 2003, there was a real resurgence of the Atkins diet. And as a result, this prompted some interest around clinical investigations. And the first of these was done by Foster. This took a group of 63 obese men and women. They were randomized into 2 diets, your conventional low-fat diet and a high-fat, low-carb diet. These were consuming the same number of calories. This study found at 6 months a significant reduction in weight in the low-carb group, but by 12 months that had vanished. And this is very common in these studies. You'll tend to get everybody loses weight at the beginning, and then it narrows with the recidivism, and people are not as compliant. But interestingly, at this point, people were starting to say, well, so what? I mean, okay, eating fat might not make you fat, although most people still believe it does. But clearly it leads to heart disease, right? So, the line offered by Dean Ornish at the time was, look, if it's all about losing weight, you can take up heroin, right? It's about health, right? And I agree with that. It's about health. I mean, weight is just one proxy for health. But anyway, let's take a look at health. So you'll recall from our discussion about what took place in the late 70s and early 80s, and what was then reemphasized in the late 90s with the sort of elucidation of metabolic syndrome, that the 2 things that are completely irrelevant is your concentration of LDL cholesterol and your total cholesterol. The 2 things that are probably relevant is the concentration of your high-density lipoprotein cholesterol, HDL, and your triglycerides. And what do we find in this study? Even with modest compliance, the group that was on the low-carb arm compared to the low-fat arm had a significant increase in their HDL and a significant decrease in their trigs. There was no difference in LDL, and there was a slight increase in favor of the low-fat group in total cholesterol. One of my favorite studies, probably because I know the author personally and have spent a lot of time talking about it, but also because I think it's a very interesting study, and it was a very well-done study, is the A to Z trial. And as you can see, A is Atkins. Anyway, the point was this was a study that took about 80 people in 4 different arms, so about 300 people, and these people were now randomized to one of 4 different diets that spanned the entire spectrum of dietary intervention. So on the one hand, you had the Ornish group that was eating 0 saturated fat, all fruits, vegetables, whole grains. At the other end, you had the Atkins people on bacon, eggs, cheese, and then you had the Zone group, which was 40% carb, 30% fat, 30% protein, and then you had Learn, which is effectively the sort of USDA DASH diet. Now, something to note about Christopher Gardner, who, by the way, there's a fantastic lecture online that he gives on YouTube when he first presented these results. Christopher is a vegan, and he commented to me, and he's commented publicly, that the results of this study were upsetting and shocking to him. Because as a vegan, you know, he eats an Ornish-like diet. Now, Christopher does it for, you know, sort of ethical reasons, not necessarily health-related reasons, but nevertheless, he found this very shocking. And as you can see, the Atkins group, which, by the way, when you look at the compliance between 2 and 12 months, you can see how everybody kind of moved back together. So at 2 months, the Atkins group was truly a low-carb, high-fat group, and the Ornish was clearly, you know, doing their best to be low-fat. But you can see that by the end, the Ornish group was effectively eating, you know, a greater amount of fat, et cetera. The Atkins group had crept back in their carbohydrate. But nevertheless, the Atkins group experienced a significant reduction in actual weight loss, in reduction of triglyceride, increase in HDL, and reduction in diastolic blood pressure. Another trial that was done 2 years later, 1 year later, was the diet trial called the Workplace trial. This trial included 322, I think, obese, I think it was just men, and they were randomized into 3 groups, so about 100 people per group. And this time there had 3 dietary interventions. So a third of the people were put on a low-fat, calorie-restricted diet. A third of people were put on a Mediterranean, also calorie-restricted diet, and a third of people were put on a low-carb ad libitum diet, meaning you can eat whatever you want as long as you don't eat carbs. What you see here is the intervention over 2 years by month on their weight change. And again, there's this very typical pattern where a lot of people kind of drop their weight, and then at about 6 months, people tend to slip back into the former, they sort of, there's this convergence again. But nevertheless, you can see that the low-carb and Mediterranean group had a significant reduction in weight loss relative to the low-fat group. And when you looked at biomarkers in blood, now this table is a little confusing, let me explain the colors to you. Red means it was a significant change within the group from their baseline. So when you took, for example, in the low-fat group, they actually had a significant reduction in their level of systolic blood pressure relative to where they were when they started. Green means no significance, and purple means it was significant across the group. So for example, the rise in HDL, high-density lipoprotein cholesterol, in the low-carb group was not only significant relative to where it was in the beginning, but was significant relative to everybody else. And so you can see here that everybody experienced a benefit in blood pressure. Nobody really experienced a benefit in LDL change. Everyone experienced a benefit in HDL, but most of all in the high-carb group. And again, think back to what was discovered in the first cohorts of Framingham based on that lipid analysis, which was the people who were eating the most fat and the least sugar and grains and highly refined carbohydrates had the highest HDL. So this shouldn't be surprising. The same thing is true on the triglyceride side, and obviously your total cholesterol to HDL ratio, which really isn't that important, but people seem obsessed with it. It's also worth noting that the hemoglobin A1C, which is a pretty early predictor of diabetes, was only significantly reduced in that group as well. So, you know, that's kind of it for the talk. I've got a couple of slides left, but people often ask me at this point in time, it seems like what you're saying is too ridiculous to be true. How could this have taken place? And I really divide it into 2 categories. There was the pre-1984 rationale for all of this. And, you know, I say, why the confidence? Well, before 1984, this almost religious zeal and belief and conviction that fat must be bad was really based on observations of populations that consumed low amounts of fat. So when we looked at populations that consumed little amounts of fat, we noticed that in some of those cases they had no heart disease. We couldn't get off this fixation. Now, you know, it's long acknowledged since that time that there's a whole bunch of other things they weren't eating. They also didn't eat any sugar. So when we talk about contrasting the wealthy people that were eating all the fat and the poor people that weren't, well, they also weren't eating sugar and they weren't eating a whole lot of other things as well. Post-1984, I would say that the greatest issue leading to the overzeal of confidence probably has to do with the cholesterol-lowering drugs, which no doubt, from a secondary prevention standpoint, have in most cases reduced cardiac mortality. In other words, there's no evidence of this in primary prevention, but for secondary prevention, when you take people who are at known risk, who have had heart attacks, and you put them on medications that lower cholesterol, we do see their numbers getting better, and we also see their risk of subsequent disease getting better. But it's really important to keep the following in mind, and never forget this. Drugs and diets are not comparable. Drugs have multiple actions, as do diets. And to say that a statin reduces a heart attack because it lowers your serum level of cholesterol is like saying that aspirins reduce heart disease by curing headaches. Aspirins do a lot of things. They thin out platelets, and that in some people reduces the risk of heart disease, but they also get rid of headaches. There's no causation there. And so while it is true that a lot of drugs happen to lower some fraction of cholesterol one way or the other, it says nothing about what they're doing to heart disease risk. And I'll close with sort of one of my favorite quotes. For the greatest enemy of truth is very often not the lie, deliberate, contrived, and dishonest, but the myth. Persistent, persuasive, and unrealistic. Too often we hold fast to the cliches of our forebears. We subject all facts to a prefabricated set of interpretations. In other words, we enjoy the comfort of opinion without the discomfort of thought. And I would offer that that's exactly what's taken place over the last 60 years. So thank you for your attention.